Welcome everyone to this webinar. We have a lot of people joining us today, and so we thought we will give it 1 more minute to allow more people to join, so just bear with us. We actually have people from all over the globe that have registered. I mean, a large group from the US, we have people from Brazil, other countries in Latin America, Europe, South Africa, Middle East, India, South Korea, China, Japan, Australia, and so on. So, yeah, a few more seconds before we start.
Really nice.
Okay, I think we are now 1 minute past. So a warm welcome to everyone to this webinar about data-driven diagnostics in neurodegenerative disorders and how to make data meaningful. My name is Lennart Turfjell. I'm the CEO for Computerized, the company organizing this event. So in the area of data-driven diagnostics, in the area of neurodegenerative disorders, we are collecting a lot of data. We have imaging data, MRI, sometimes also PET. We have CSF biomarkers. We have results from neuropsychological tests. We have other clinical data, sometimes genetics and so forth. And it's a challenge for the clinician to put all this information together. And today we're going to learn more about how AI and machine learning can help clinicians to extract all the information in this vast amount of data. So it's a pleasure for me to introduce today's speaker, Dr. Hanneke Rhodious-Meester from the Alzheimer's Center in Amsterdam. Hanneke is a clinical geriatrician at the center, and when she's not seeing patients, she's conducting research in the use of biomarkers and diagnostic tests in clinical practice. After the presentation, we will have a Q&A session, so please prepare questions and enter them into the chat window. You can do that during the presentation or when we start the Q&A session. So, without further ado, let's move on with the presentation. So, Hanneke, the floor is yours.
Yeah, thank you so much, Lennart. And really nice to be able to talk to you through this medium. Just a small note, please put your questions in the question box. That's easier to organize afterwards. And I'll just share my screen with you. And there we go. These are the disclosures of the Alzheimer's Center, Amsterdam. As Lennart said, there's a lot of debate in the media on artificial intelligence and the use of it in medicine. And in this presentation, I'll introduce you to 3 different developments in data-driven diagnostics. First, I tell more on the basics of clinical decision support systems, then on automated MRI quantification, and finally on a stepwise approach to select patients in which CSF is useful. And I'll do so guided by a 73-year-old patient visiting the memory clinic. We all know dementia is a growing challenge, affecting more and more patients each year. And for all these patients, an early and precise diagnosis is essential, both for care and for cure. But early and precise diagnosis is easier said than done. A diagnosis of dementia is the outcome of a multidisciplinary workup. And as clinicians, we have an increasing number of diagnostic tests to aid us. And this makes working at the memory clinic very interesting, but also more and more complex. For as a clinician, I face many challenges. For example, how do I take into account all available information? Am I really able to look at the MRI scan and think about the cognitive test results at the same time? And how do I know in which patient which test is useful? Furthermore, literature is often about comparing healthy controls with Alzheimer's disease, while clinical practice is about differential diagnosis. Is it this type of dementia or that type of dementia? Let me illustrate this challenge with this memory clinic patient. She's a 73-year-old female with a history of depression, hypertension, and a heart attack. And since 3 years, she has been experiencing memory and word finding problems. At neurological examination, there are no abnormalities. And MMSE, the global screening test for memory impairment, is 25 out of 30. Cognitive testing revealed impairment in memory and executive functioning, plus she was slower than expected. MRIs showed only mild atrophy and confluent vascular lesions, and we had no CSF in this patient. Well, how to combine this information? The experience, complaints, and memory problems points towards Alzheimer's disease, but then I'd expect more atrophy on the MRI scan. And the executive problems, slowing, and medical history points towards vascular dementia, perhaps FTD. Is this Alzheimer's disease or vascular dementia, frontotemporal dementia, or both? And what to say to my patient? And I'm wondering if a computer tool could help in this challenge. A computer tool could help by combining and visualizing data, providing overview. But the tool should also be able to deal with conflicting and missing data, like clinical practice, and should be able to compare different types of dementia with each other, because this is what clinical practice is all about. And this aim was also part of the objectives of the PredictND project. PredictND was a large European project in which we collaborated with several international partners, both clinicians, imaging, and software engineers. And together we developed a computer tool to support clinicians in the challenge of differential diagnosis of dementia. The developed computer tool is a clinical decision support system. And this might sound complex, but it's not, and I'd like to explain it. Basically, the tool is a way of combining and visualizing data to support the clinician. To do so, we first enter the data of one patient, such as cognitive tests, CSF, though not in the patient I just presented to you, but also raw MRI images. As a next step, the tool analyzes all this data. And an important part of these analyses are the automated MRI quantification. In clinical practice, it's often complex to obtain all the information that is hidden in the scan. How to extract this information? Visual rating skills, such as the medial temporal lobe atrophy scale, the MTA, are a step towards quantification, but they are still subjective and relatively coarse. Plus, not all doctors assess them. A recent survey among radiologists showed that 32% of respondents are not fully confident in using visual rating skills, while only 54% of the radiologists rated the MTA always. So there's room for improvement. The tool we developed gives the clinician the opportunity to go through the scan in a very easy way and provides a lot of extras. And I'd like to highlight two features. In PredictND, we, for example, developed a method to compute the commonly used visual skills automatically. So the tool estimates the medial temporal lobe atrophy scale, the MTA, the global cortical atrophy, the GCA, and white matter hyperintensities as measured with fasciculus. Here in the figure below, you see in green the performance of the visual rating skills, so as it's done now, and in yellow the computed rating skills, and their performance in separating different types of dementia and controls in two big cohorts. And you see that the computed skills give comparable or even, the printer is going, that was unexpected. Excuse me, I'll just wait till it's done. I turned everything off except the computer. Okay, where were we? Well, yeah, you see here in the figure that the computed skills give comparable or even higher accuracy in separating the different types of dementia. On the left, you see the MTA skill, and you see that this skill, both visual and computed, is best in separating AD from controls. On the right, you see the physique skill, and of course, this skill is best in separating vascular cognitive impairment, VCI, from controls and other types of dementia. You also see the separation between, for example, Alzheimer's dementia or frontotemporal dementia is difficult for these measures. And to add in this difficult separation, we derive novel measures, such as the anterior-posterior index, or the API. Here we compare the ratio of the volume of the frontotemporal region with the volume of the occipito-parietal region. In the figure below, you see the API score on the y-axis and the different types of dementia on the x-axis, with the FTD subtypes all the way to the right. And you see a clear distinction between the diagnosis left and right. And in this study, we found an area under the curve of 0.83, which shows this measure really aids in the difficult separation of FTD from other types of dementia. Well, back to the tool. After all the data has been quantified, the next question is how to combine all the data in a systematic way. And we use the disease state index classifier, which compares all the data of my patient to a high number of previously diagnosed cases, and measures how similar my patient is to Alzheimer's dementia, frontotemporal dementia, vascular dementia, and controls. This is shown both in color and in number. The number is the disease state index, the DSI, which is a value between 0 and 1, where 1 means the data matches perfect with the suggested diagnosis, and 0 means the data does not match at all. The color varies between red and blue. And for this patient, the data fits best to vascular dementia, which is shown by the high DSI of 0.75 and the color red. And the second best is Alzheimer's disease. The probability that the suggested diagnosis with the highest DSI value is correct is 65%, the probability of correct class. In our patient, the PCC is 65%, which is not very high. And this we can also see from the DSI values, where we see that the difference between the DSI value for vascular dementia and Alzheimer's disease is fairly small. And although the DSI classifier is based on machine learning, it's not a black box. Because how the tool has come to its conclusion can be seen in the fingerprint. And in the middle, you see here the tree-like structure that summarizes all data. The tool contrasts here vascular dementia and Alzheimer's disease, as those were the two most likely diagnoses for this patient. And you see in the visualization in the middle again the colors red and blue, but also boxes. The larger the box, the larger the contribution of the specific determinant to the prognosis. And the more vivid blue, the more the determinant matches subjects, like here Alzheimer's disease. The more vivid red, the more the determinant matches a certain disease, in this case vascular dementia. And that leads me back to the patient I introduced you to earlier. I showed you I'm struggling with combining her medical history, the cognitive test results, and the MRI. Is this vascular dementia, Alzheimer's dementia, or frontotemporal dementia? And how would the tool help me? And here you see a screenshot of what happens when we enter the scan of this patient into the tool. This is the T1 scan, and you see that the tool automatically segments the brain into 133 regions. And I could go through the scan to see how the brain looks like. On the right, you see the results of the automated T1 analysis. Given the memory complaints, I'm of course interested in the hippocampal region. And you see here the volume of the hippocampi. And it's around 3 milliliters on both sides, on the 4th and 2nd percentile. And this means that 2 and 4% of age-matched healthy controls have smaller volumes than my patient. And the tool also automatically computes visual ratings and corrects them for age, like here the medial temporal lobe atrophy scale, the MTA. And the MTA is on both sides around 1. And this is the 97th percentile, meaning that 97% of age-matched healthy controls have a smaller rating. So the volume of the hypocampia of my patient is smaller than expected for healthy patients, people at this age. On the other hand, the anterior-posterior index, that's well in discriminating vascular or frontotemporal dementia, is normal. And this makes FTD based on the T1 scan less likely. And this is the FLAIR scan. On the left, you see the white matter lesions in red. And the tool computes the fasciculus, which you see on the right. This patient has a fasciculus of nearly 3. And when compared to age-matched healthy controls, more than 99% have smaller ratings, so less white matter hyperintensities. This is also shown in the figure on the bottom, where you see the patient as a yellow dot. So again, not only her hypocampia are smaller than expected when compared to age-matched healthy controls, but also her white matter hyperintensities are more than expected for her age. So is this due to Alzheimer's disease or vascular dementia? For this, after the MRI analysis, the tool combines the data or the MRI data with the demographics and the cognitive test results. And these results are visualized in the fingerprint, as you see here. And you can select any pairwise comparison of diagnosis. Let's first look at the total scores. At the upper row, you see the 4 diagnoses that the tool compared the patient with. The first diagnosis is the diagnosis with the highest DSI. So the data of the patient matched mostly patients with this diagnosis. Here it's vascular dementia with a DSI of 0.75. And as a second most likely disease, you see Alzheimer's disease with a DSI of 0.66, meaning the data of the patient so far resembles vascular dementia most, but the value for Alzheimer's disease is actually quite close, shown also by the PCC, that's only 65%. And you see that the DSI for FTD is 54, making this diagnosis unlikely. When we look at the fingerprint comparing vascular dementia with Alzheimer's disease, you see how the tool has made its conclusion. Now, everything that is red points towards vascular dementia, for example, the white matter hyperintensities and the animal fluency on the bottom. And blue points towards Alzheimer's disease, for example, the hippocampal volume and the bad memory, the bad recall. When we look at the figure at the right, we see the distribution of vascular dementia patients in red and Alzheimer's cases in blue. And this patient is mostly in the vascular dementia part of the figure, as you see by the yellow line, but there's overlap with Alzheimer's disease. So the tool in this case shows that existing data does not enable clear diagnosis and additional testing should probably be considered. And I'm wondering if CSF might help in this patient, for I know that information about amyloid status might bring clarity also in this case. To facilitate optimal use of CSF biomarkers, the appropriate use criteria have been published. Yet these criteria are rather vague and difficult to translate to clinical practice. They state, for example, that the clinician should first know how CSF contributes to the confidence in the diagnosis, and that CSF can be performed in all patients suspected with Alzheimer's disease, which is hardly feasible in clinical practice. So as a clinician, how do I know in which patients CSF is useful when compared, for example, with additional testing costs and its invasiveness? After all, I only want to perform a lumbar puncture if it's of use. And we wondered whether the developed tool could help in selecting those in whom CSF most likely contributes to a more accurate diagnosis. Using this tool, we selected patients for CSF using a stepwise data-driven approach. First, we measured the disease state index, the DSI, and the probability of correct class, the PCC, based on cognitive data and MRI. When the diagnosis is not confident enough based on PCC, we go to the next step. In this step, we add simulated CSF values, both for positive AD and negative control-like CSF results. And if the simulated CSF values change the diagnostic confidence, in other words, when the PCC increases, then it's useful to perform CSF. And we tested this approach in more than 500 memory clinic subjects and compared it to 3 different approaches, where we looked at proportion of patients with a confident diagnosis and proportion of CSF performed. In approach B, we only used cognitive tests and MRI and no CSF to come to a diagnosis. In approach C, we applied the appropriate use criteria for CSF. And in approach D, we performed CSF in all patients. So the diagnosis was based on neuropsychology, MRI, and CSF. And here you see the results of our 4 diagnostic scenarios. When we used only neuropsychology and MRI in scenario B without CSF to come to a diagnosis, 58% of the patients received a diagnosis with sufficient confidence. In the computer-supported approach, we then added simulated CSF results for the remaining 42% of cases that did not get a confident diagnosis. These simulated CSF values increased the confidence in the diagnosis in half of the patients, and in those patients we actually added CSF, leading finally to 71% of patients with a diagnosis with enough confidence, while we performed CSF in only 26% of the cases. For both the appropriate use criteria and CSF all, so scenario C and D, 65% of patients received a diagnosis with sufficient confidence. In scenario C, we needed to perform CSF in 55% of the cases, and in scenario D, of course, for all cases. So to conclude, the computerized supported approach yielded the largest proportion of diagnosis with sufficient confidence, whereas we performed CSF in only 26% of the cases. So how could this work in clinical practice? For that, I take you back to the 73-year-old female in whom I doubt between Alzheimer's disease and vascular dementia, and wondering whether CSF is useful to perform or not. According to the computerized approach, the tool first makes a diagnosis based on neuropsychology and MRI. Using this, as I've shown you before, the PCC remains below 75, a cutoff that's used or chosen here, meaning the diagnosis is less certain. Then we add simulated CSF values. With positive AD CSF values, the confidence remains low. You see the PCC is 68%. But when we add negative simulated CSF values, the confidence or the PCC increases to 77%. So meaning CSF potentially increases the confidence in the diagnosis. So this would be reason for me to perform CSF in this patient. And CSF showed borderline abnormal amyloid beta, as you see on the right, abnormal tau, and also abnormal p-tau. When we add this to the tool, the diagnosis with the highest DSI changes from vascular dementia to Alzheimer's disease, yet with still a high DSI for vascular dementia as well. And the PCC increases from 0.765 to 0.71. This you also see in the figure here on the right, where red is Alzheimer's disease and blue is vascular dementia, and the patient moved towards Alzheimer's disease. So to conclude, I will now explain my patient that she has Alzheimer's disease, causing her memory complaints and word-finding problems. But possibly vascular damage plays also a role, given the slow speed she has. And I think this diagnosis is important for her, for treatment and also prognosis. I'll start on cholinesterase inhibitors, which I would not have done had this been vascular dementia. And I will tell her there's a large chance her problems will increase during the coming years. Another thing that's often not so clear in case of vascular dementia. So to wrap up, how can we make use of artificial intelligence, making data meaningful in memory clinics? My patient and I have shown you how tools we developed could combine and visualize all data in a comprehensive way and thus provide overview for the clinician. The Predict and D tool was able to deal with missing data, as is common in daily practice, and adds with fully automated MRI analysis. Plus, the tool was able to differentiate between several pathologies, and that's what clinical practice is all about. And finally, the tool can simulate CSF results, and in that way guide clinicians in whom to test and whom it's not useful to perform CSF. So overall, tools like the Predict and D tool do not make a diagnosis, but they support the clinician and increase confidence on making decisions, enabling personalized diagnosis. And this will lead to better care and cure for our patients. And with that, I'd like to thank you, and I'm of course happy to discuss it further with you.
Thank you very much, Hanneke, for this presentation. So we now have the Q&A session, so I encourage you to enter your questions into the questions field in this chat area. So while waiting for questions to come in, let me start with one question. So maybe obvious in this time, so I'm thinking about with the current COVID-19 situation, I mean, are you changing the way you are working, and do you see a need for new tools, or I mean, maybe working from home, or so? Could you give us some thoughts on that?
Yeah, of course. Yeah, I think we've all been struggling with that these last months, and we are now at the moment we're seeing our patients when they come to our clinic live again, but when we have to discuss the diagnostic results and explain diagnosis to them, we have to do it online. Plus, for example, the consensus meeting is only attended by a few doctors now, and most of the doctors, they log in from home.
Yeah.
So this makes it very challenging to get an overview on what we're discussing in the consensus meeting and what to explain to your patient. And I think that developments like the Predict and D tool could be really helpful in, for example, when you share your screen with the patient, or when you share your screen in a consensus meeting, to provide overview. And if you think about the fingerprints, it might be really helpful to get a better view on all the tests available. We've just started a new project where we aim to develop a communication module with patients, so patients will be more able to understand the diagnostic test results. And I think this is also very important inside of online working. Yeah. I think another nice thing would be if that clinicians would be really helped with online cognitive testing. And just last week we got message that a paper on this subject has been approved for publication, Alzheimer's and dementia. So hopefully you can read more about that soon.
Yeah. Okay. Thank you for that. So we have some questions coming in now. So let me start here. What kind of data did you use in the developed tool? Let's see here. And what kind of predictions can you provide in the tool? And how do you quantify the MRI images? Maybe that's something that I can add on later also, but if you go ahead.
Yeah, for the developed tool, we use several data sets to train the tool on. For example, from our own Alzheimer's Center, our Amsterdam dementia cohort, but also, for example, ATME, and in the European Predict and D project, where we were able to gain information from several European memory clinics. Regarding the predictions, the tool is, we invested, of course, the diagnostic accuracy for separating the different types of dementia, which was high. When you compare 5 classes, it's around 80%. But we also worked on if the tool is able to predict progression in patients with MCI and even subjective cognitive decline. And there we see especially a high negative predictive value. So if the tool can really be used to reassure the patients and select those that need to come to the clinic further.
Yeah. Okay, moving on. So could you explain a little bit more about how medical history and cognitive test results contribute to your prediction model? What if there's contradiction in these results? So I think cognitive test results, I think that was part of your presentation, but maybe you could explain a bit further.
Yeah, medical history is not part of the prediction model, but cognitive test results, of course, are. And I think the really nice thing about the tool is that it's very able to deal with these contradictions. Because as a clinician, I often think you often don't know what to weigh best, but the tool takes into account for all different variables, the feasibility of the variable and the strength of the variable. So variables that contribute a lot to the diagnosis will get more weight as compared to variables that are not so able to discriminate between different types of dementia. So I think the nice thing is that you take into account all these contradictions and weigh everything together. And as I've shown in my case, often patients have different pathologies leading to their symptoms, and that's nice thing that the tool really acknowledges that. So it's not just one diagnosis, but a certain amount of variables fit to this diagnosis and a certain amount of variable fit to that diagnosis. And when you wrap it all up, you come to a conclusion. So extremely clinical.
Yeah, thank you. And an interesting question coming in here. I know it's still too soon to be sure about it, but some neurologists believe that the cases of dementia or maybe cognitive decline will increase in the future due to COVID-19. Is that something that you have any...
I did read about it. I don't have a strong opinion on it, nor expertise on it. But it has been in some neurologist papers here in the Netherlands as well. So I'm thinking about pathology or a pathological connection. But I'm also fearing, and that's something I see quite a lot in the clinic now, that patients, they hesitate to go to the hospital or to the GP. So patients are being diagnosed later as well. So that's rather sad.
Then we have a question here. How long has this tool been available? And is it available to all clinics? Maybe that's a question I could address because I wanted to wrap up this session with a few slides. So, and then amazing tool. How does the model perform in early dementia cases? For example, when there is no significant pathology yet?
Yeah, we did a study with subjects with subjective cognitive decline, so the worried well or the preclinical Alzheimer's disease, a pre-symptomatic Alzheimer's disease. We did this in Neuro STD cohorts, and we found that the tool was really accurate in picking out the patients with stable subjective cognitive decline. So already in these very early cases, you see slight differences on cognitive testing and also on MRI, and the tool is able to detect that. So that's an interesting development as well.
Thank you. And then we have a question. Recent literature has shown that PET tau imaging is more accurate than MRI and CSF markers for differential diagnosis in dementia. Are you planning to include PET data in your tool? And that's, maybe that's also something I could address Or do you want to comment on that?
No, I was going to say that I think especially for older patients, it would be very interesting to be able to take tau into account more often. We are working at the moment now on a data-driven approach to select patients for amyloid PET, a bit analog to the CSF part I showed you. And I'd be very happy to have tau PET available in clinic as well.
Yeah, and I guess tau PET will not replace MRI because you will do MRI anyway, so it will be a complementary technique. Okay, let's see here. Another question. Great work, congrats. There's quite a lot of about the model ability to deal with the contradictions if confounding factors are not plugged in. Have you tested this trend with diabetics? I'm not sure actually what.
No, you can of course imagine that certain cardiovascular risk factors and diabetes are affecting how patients present and affect their symptoms. We did not include that in the models yet, but I think it would be interesting for various reasons. Also, if you think about personalized risk treatment.
And then we have a question: is the tool able to predict progression of disease? I mean, we have talked about differential diagnosis, but what about progression?
I haven't looked at it longitudinally.
But the progression from MCI to
of course, but not from the, in our work we have not been able to predict if patients already have a dementia, which patient will progress fast and which patients will not progress fast. So that would be really nice to do as well. But for SPD and MCI, we are able to predict
from MCI to dementia and from okay, so let's see. Okay, we have also a question. What preventative techniques would you suggest for Alzheimer's disease in the middle adulthood stage? And screen is not showing the whole text here, so it's I'm guessing a bit here. I mean,
I think it's really
to delay symptoms later in life and so on.
Yeah, I think that's something. There's been a lot of research going on right now, which is really nice. I think recently Euro Finger project has started as part of the worldwide fingers, in which Miyake Vipalto is increasing the efforts in researching that. And I think so far data has shown it's important indeed to all the things that that's written in the question to exercise, the Mediterranean diet, cognitive training. I'm not sure if that's helpful at middle adulthood stage. At least education earlier in life is important. So these are the basics, and I'm really interested. Really great that there's so much attention for that now.
Okay, so I think maybe we should, we will go through this list of questions, and if there's something that we have not addressed, I mean, we can also get back to participants with the emails. So maybe we should move on now, and I will end this presentation with this webinar by showing a few slides. So I wanted to just say a few words about Computerized. Computerized was founded to develop a regulatory approved tool based on the results from this EU project that Hanneke has been talking about. So we are focusing on providing tools to help radiologists and neurologists to diagnose and track progression and predict progression in patients with suspected neurodegenerative disease. So working both in dementia, but also multiple sclerosis and other neurodegenerative diseases. So we have developed a platform called Neuro. This is a cloud-based zero footprint system. So the viewer runs in your standard web browser. No need to install any software. We have a module, CMRI, for quantification of MRI brain images, these 133 regions. And then we have a module, CDSI, which is all about combining imaging data with clinical data along the lines that we have just heard. Neuro is FDA cleared for the US. It's CE marked, so regulatory approved in Europe, and also regulatory approved in Brazil, and availability for other countries on a case-by-case basis. So for those on the call that will attend the virtual AIC meeting next week, I welcome you to visit the Diagnostics booth. So we have a virtual booth there to hear more about Neuro and to meet our people. And today, in today's webinar, we have really focused on the needs by the neurologists. So how can AI, machine learning, help combine all this data? Of course, the use of AI tools to help radiologists assess images, we have touched a bit on that, but there's quite a lot more to say. So how can AI help radiologists analyze cross-sectional and longitudinal data, how extract disease-specific patterns and minimize variability in longitudinal assessment? And this will be the topic for an upcoming webinar. So with that, we are ending this webinar a bit early, but we would like to again welcome you to our AIC booth next week, and we hope to see you at upcoming webinars. And with that, I again want to thank Hanneke for your presentation, and I want to thank all the participants for listening to this webinar. Thank you and have a good day.